Thank you. At the onset, I'd like to thank AIOC for giving me this opportunity. My colleagues have gone through the difficult cases of different causes of optic neuropathy, and I'm going to talk to you briefly on decoding the pupil. As you know, the pupil forms an important part of the neuro-ophthalmological examination. Both the size, shape of the pupil. The size of the pupil is determined by different factors, a combination of the ambient light, sympathetic and parasympathetic supply, and the balance between them. The range of pupil size can be varying from 2 to 6 millimeters. Usually we find 3 to 4. And there can be physiological anisocoria. A difference of 1 millimeter is seen up to 20% of people, but 2 millimeters or more difference is significant. The parasympathetic supply, we all know, starts from the midbrain and then goes forwards through the third nerve, ciliary ganglion, and then finally to the iris. So lesions anyway along this can influence the pupil size. Usually we see third nerve palsy, tonic pupil of Eddys, and obviously very severely ill patients usually don't present to us, but can be present in multi-specialty hospitals. Again, the sympathetic supply starting from the brain down through the neck, and then in the upper part of the thorax, and then back up again along the carotid artery, and this can be tested with the cerebrospinal reflex. Again, lesion, the usual ones that we see is Horner syndrome. And I'll be showing you examples of these. The near response is equally important, especially when the light response is negative, then all the more importance for the near reflex. Near reflex, as we know, you have a convergence, accommodation, and meiosis happening, and the stimulus can be either via the fifth nerve or via the visual pathway. Just like in any case, history is very important. You can ask for history of blurring of vision, double vision, so other associated pathologies, other cranial nerve involvement, headache, numbness, face, neck, and arm pain, all features with us clues regarding the etiology of the problem. Any history of trauma, whiplash, and now of late, as you know, this head and neck massage is getting more and more popular, and we can probably read in newspapers about cases after a head or neck massage, people getting problems like a stroke and things like that. So these are different types of etiologies that can present to us. Systemic disease, diabetes, thyroid, other neurological diseases, and malignancy. Sometimes when you see a patient with an asymmetry of pupil, and we are suspecting whether it's physiological, a very good thing would be to look at old photographs. So that will give us a clue about how long it has been there. Examination, it has been covered by my colleagues, vision, color vision, associated features, lid proptosis, extraocular movements, visual fields, and other cranial nerves. So if you're getting isolated, say a pupil abnormality with associated cranial nerves, then obviously it gives clue as to the site of lesion. Superficial temporal artery, as my colleagues have just said, check the neck, check the hands. And you can record the pupil size, is the pupil gauge, the shape of the pupil, size of the pupil, both in ambient light, in dark. Then check the light reflex, direct, consensual, and the swinging flashlight test, and then the near reflex. And it is important, but usually afferent pathway problems don't cause anisocoria. Now, if the pupil is equal, obviously check for, important to check for RAPD in every case. And then with anisocoria, it can be physiological or pathological. And then the possible etiologies can be any of these pathways. So this case of trauma, you can see this is, unfortunately, that I checked that the video is not playing. Got a hemorrhage here, and this patient had an afferent pupillary defect, although there's actually no obvious injury to the globe. When you see an asymmetry of the pupil size, then the abnormal pupil may be either the large pupil or the small pupil. Large pupil, the usual ones we are thinking of are third nerve palsy and Eddys tonic pupil, or it can be, we may be the cause by trauma or surgery. Surgery, you know, sometimes we use iris hooks. All these can distort the pupil, which may stay like that. Small pupil, usually the one that we see is the Horner syndrome, and occasionally Argyll Robertson pupil. Again, cases of uveitis, whether synechiae, all these, and pharmacological long-term use of pilocarpine causes small pupil, but usually that is bilateral. I'll show you a few examples now. So important to remember that anisocoria is up to, as I said, 1 in 5 people can have it. It's usually asymptomatic. Important thing is that the reaction is good in light and dark, and no other features. And important to remember that the size and the side may change. The usual, when we see in the books, this is the usual algorithm they use to analyze anisocoria: worse in dark, worse in light, or similar in both, where it is more sensitive or physiological. Sometimes it is difficult to actually measure the pupil in the dark, and then we may be in a bit of a confusion as how to proceed. Now, the usual algorithm I use is important giving emphasis to the light reflex. So see the light reflex and see if the larger pupil is abnormal to light reflex, most likely the abnormality is there. I'll show you and illustrate this through an example. So this is a patient I saw while I was working in the UK, and you can see the this difference in the size of the pupils. Now we don't know which is it this one or this one that is abnormal. But as you can see, there's an associated feature. There's a slight ptosis there as well. So when you use this, and usually these people, they react well to light. So that you can see the good reaction to light. The small then you know that the small pupil is the abnormal one, and then look for other features. Like in this case, there is a ptosis, and that gives a clue that this is a Horner syndrome. This was actually a patient who is actually a karate instructor, and he had actually obviously had an injury to his neck. And if you look here, we did a CT. It was actually a dissection of the carotid, which had caused the Horners in the left eye. Can I play have you a mouse? I wanted to mouse to play the video. How can I play the video? Scroll back. Okay, fine. Now, Horner syndrome, sometimes you may not actually get a smaller pupil, but even a delay or what is known as a dilation lag is actually a feature of Horner syndrome. Of course, this can only be done with this type of camera which can record in a dark situation. So a delayed dilatation also is a feature of Horner syndrome. The other important feature is if it's a long-standing Horners, you'll also get heterochromia. As you can see in this patient, you can see the difference in the iris, and also you can see the ptosis on the left side. Another example, this is a lady I saw a few months ago, 43-year-old with typical presbyopic symptoms, and she actually came with a complaint of headache, and I thought it was due to the presbyopia, but incidentally I also saw the difference in the pupil size here. So going by the same algorithm, check the light reaction, no reaction. So from that we say the larger pupil is the abnormal one. Then look for other features, ptosis, extraocular movement problems, nothing was there, no. And then you look at the near reaction. In this case, actually near reaction was also absent, but looking on the slit lamp, I could see vermiform movements. So from this, we narrow it down to a tonic pupil. I'll show you her, because the patient had a severe headache and the family was very worried, we did send her for neuroimaging. Neuroimaging found out something, a tuft of vessels in the right parietal region, which is really couldn't connect it to the patient's problem. But obviously, they were very concerned, and a detailed investigation all turned out to be negative. So from that, we could say it is an Eddys pupil, and I'll show you the video. So that's the pupils, left and right. Sorry. Video. Yes, video. It's not coming. Thank you. So if you please watch the video, just watch this part of the iris. You can see it very clearly over here. There you can see. You can see the vermiform movements. It's very nicely seen in this patient. So as you know, our books say vermiform movement are there. It is characteristic of Eddys pupil, and you don't need further investigation. But in this age of medico-legal issues, I think we have to be defensive. And so this patient was completely investigated and everything else was normal. Of course, then you also have third nerve palsy. This patient was a pupil-sparing third nerve palsy. Obviously, you have the ptosis and other, you can see the eyeball is down and out. While this patient actually had a cataract surgery, and going back from the surgery, she actually fell off a scooter. And you can see she had the injury there, and her daughter was driving the scooter, and she had a pupil involving third nerve palsy. Fortunately, again, you use the same algorithm. That's easy. Last pupil is abnormal. Other features, and this is third nerve palsy. And fortunately, she recovered in a few months' time. Then you have the light-near dissociation, and usually called the Argyll Robertson pupil. Now, Argyll Robertson pupil can be smaller or larger. So sometimes it is a bit confusing depending on the cause. So you can see if the typically midbrain lesion, it is smaller, while you have the dorsal midbrain syndrome where the pupil may be larger. So you have the light reaction is absent, but near reaction is present. So the size can be varying in Argyll Robertson pupil depending on where the lesion is. It can also be due to an anterior visual pathway lesion or aberrant regeneration of third nerve, which actually simulates Argyll Robertson pupil, and show you an example of that. And extensive laser or retinal cryotherapy can also cause this. And if a tonic pupil, if the near reaction is present, obviously in the Eddys pupil can also have the same features. Last case is a case, again, I saw in the UK at the previous, he presented with, you can see, ptosis, diplopia, and you can see the eye is down and out, typically like a third nerve. But importantly, as you can see, when the patient looks to the right, there is actually a constriction of the pupil, and this is actually due to an aberrant regeneration of the pupil. So it's basically a synkinesis. So this again can simulate a light-near dissociation because light reaction is absent, but on adduction, there is meiosis. So in conclusion, pupil examination should be an integral part of our examination and use a stepwise method with which you are comfortable. A careful history will give you important clues to the etiology. Thank you.